Hi, everyone. Welcome and thank you for joining us for the December episode of Chang Reaction. My name is Taylor Young, and I am the Assistant Director of the National Keratoconus Foundation. We are a patient advocacy program based in Southern California at the University of California, Irvine. NKCF provides information to patients and their families and raises public awareness of this cornea disease. We invite you to visit our website, nkcf.org, and sign up for our newsletter and to register for our bi-monthly webinars. We also post news on our LinkedIn, Instagram, and Facebook pages. This is episode 9 of Chang Reaction, our Ask the Expert podcast. Our partner is Dr. Chang, a noted keratoconus expert and friend of NKCF. We often receive questions about life with keratoconus, and Dr. Chang has offered to share his advice on these questions. NKCF records and archives these episodes for the public. You can view past episodes by going to nkcf.org/webinars. Dr. Chang is currently the Director of Specialty Contact Lenses on the Cornea Service at Wills Eye Hospital in Philadelphia. He is also a member of the Medical Affairs team at Glaukos, which is the company that makes the FDA-approved cross-linking product and equipment. He is a graduate of the Pennsylvania College of Optometry and a fellow of the American Academy of Optometry. Dr. Chang was also named the NKCF Top Doc in 2020. We also will have a special guest, Dr. Stephen Greenstein, joining us today. I'm going to turn it over to Dr. Chang to introduce Dr. Greenstein. Hope you enjoy.
Thank you, Taylor. Thank you, everybody. We have a very special guest here today to help us push us over the hump of the end of 2021. So really glad for him to make time for us today. And for those of you who are used to seeing just me and Taylor on the screen, we have a star surgeon who surely can answer every single question that we throw at him today. So let me give you a little bit of intro on Dr. Greenstein, who graduated from New York University and received his medical degree from Albert Einstein College of Medicine. And after completing a 1-year pre-residency research fellowship, which he and I overlapped at the Cornea Laser Eye Institute when I was doing my fellowship there as well. So Dr. Greenstein feels that very friendly and very comfortable for me to see an old friend who is so successful right now. And he, without doubt, specializes in keratoconus, cornea and refractive surgery. His research interests include surgical treatment for keratoconus and novel clinics for corneal surgery. Dr. Greenstein is also involved in several clinic research studies to evaluate the safety and efficacy of new therapies and methods of keratoconus and refractive procedures, some of which we're gonna get into today as well. So without further ado, Dr. Greenstein, are you ready?
I'm ready. It's good. It feels like we've come full circle here since we knew each other when I was a medical student, and now coming back this way. This is fantastic. And thank you for inviting me on. The National Keratoconus Foundation is really near and dear, and what they do for patient advocacy and education is second to none. So thank you for having me. It's really an honor to be here.
Yeah, thank you. Thank you for being our first, hopefully first of the many star guests that we'll have on this show. And you're definitely paving the way for everybody else. So you can put it to shame. And we have like an intro, we've curated a series of questions for you, which are actually coming from an international audience today. So the very first question we have is from Ahmed from India, and whose question is, can keratoconus be treated with stem cells, and how would that work?
So that's a great question. Stem cell therapy in general has really been at the forefront of medicine, and particularly in cornea. There was a lot of fanfare around stem cells being used to treat the corneal endothelium, which is kind of the back surface of the cornea, and the pumps for different diseases. There's been even more about treating the front surface of the cornea with chemical burns and some stuff that we've really been very refractory to our current surgical management. So Where we want to focus for keratoconus is using those stem cells in the stroma, in the center portion of the cornea, because as many of us know, the issue with the structural integrity of the cornea for keratoconus is that there's a loss of the collagen matrix. There's a loss of these lamellar pancakes that sit in the center of the cornea. And if we would be able to recreate the collagen, that might alleviate the need for some of our other surgical procedures that we do. So, stem cells give us the best opportunity potentially to be able to naturally recreate collagen in the cornea, and hopefully in doing so, create additional biomechanical strength to the cornea. So, where are we today with it? It's definitely a very novel treatment. It's not available in any way really for patients yet. There has been a lot of work being done on using stem cells in the stroma now. And one of the great things about the cell architecture for the cornea is that we're able to now harvest stem cells for actually human fat cells from adipose tissue, we call it, which does make it easier to at least, unfortunately, a lot of us have that readily available. So it's easy. It's an easier place to potentially harvest stem cells. And then those stem cells can change into what we call the keratocytes, the natural cells of the cornea. And so far, we've seen promising results that by using those cells, we might be able to enhance the keratocyte production and maybe even enhance collagen production in the cornea. Doing this in combination with actually adding collagen could be the next iteration of keratoconus therapy. So by adding collagen and then adding some of these stem cells, we might be able to kind of make that process go faster for patients. So it's a really exciting area. It's not quite ready for prime time yet. It's not readily available for patients just yet, but I think it is definitely going to be a part of our future.
I completely agree. And just as a branch off question, because I believe you and I get this question all the time from all the patients that you see that comes from afar to New Jersey to see you. They often ask about stem cells and how it can be applied to a corneal surface. Do you see this? And I've read there's some of the research on the extracting from the adipose cell and then and then implanted into the cornea. Do you see it as being delivery-wise? Do you think it's going to be an injection-based? Do you think it's going to be colonized and maybe implanted as a maybe a sheet or a different type of formation at a different location? How do you see this? And I know nothing's approved and we're far from. Yeah, I'm just wondering what's your prediction for the future?
Right. The short answer is we obviously don't know yet. It's clearly going to probably have to be injected into the stroma, into that center area of the cornea, so that we can get it to into the right place essentially, so that it works well. I think the two options are either we're going to find out that we can inject it directly in just the stem cells alone, and that's going to repopulate enough of the cornea. Maybe we're going to find out in more mild cases that might be enough to kind of strengthen the cornea and stop it from potentially getting worse. I think more likely early on you're going to see it as an enhancement. So we have abilities now to place collagen lamellae alone into the cornea. And this probably can be used with that in conjunction to basically enhance the collagen we put in and strengthen the cornea even more. And potentially where it also may have use is in scarring. So one of the things that has been seen on the epithelial side of the cornea, the surface area of the cornea, is that using these stem cells for different reasons than this, but it can really help the cornea remodel itself. And so it is possible that by doing this in the stroma, where keratoconus and patients with keratoconus get scarring, that we might be able to improve that as a part of this as well. And as we all know, that the scarring is really one of the more challenging areas for us to have to treat still in keratoconus. So we don't know, but that might be a really great area where it can prove to be very useful.
Yeah, that's definitely very exciting, because as you and I and a lot of patients already know this, the location of the corneal scarring is what prevents them from seeing well and a lot of times necessitating to removal of the scar, which sometimes is what leads to the need for corneal transplant, where contact lens really couldn't help deliver better vision through the scarred area. So that will be very exciting, and I'm sure you're going to be some of these change in the future too.
Yeah, I mean, corneal scarring has really been one of our biggest challenges at this point, because from a lot of our our new surgical techniques and the modern contact lens technology, we can usually find something for almost any curvature of the cornea. So whereas it used to be that steep corneas couldn't be fit with contact lenses, they can now. And whereas it used to be we couldn't surgically treat steeper corneas without transplant, we actually are learning that we can. But the one area where we still need the transplant for sure is scarring in the center of the cornea. You know, as you said, it can be in different areas, but central scarring still can be very challenging without doing a transplant.
Right, right. Well, you know, I knew I was going to learn a lot from you, and we still have more questions to go. And just the first question, we're getting such great responses. So let's go to the second one.
Good.
It's Karin, or could be Karen, but spelled differently, from Texas. And the question is, have you heard about this new corneal transplant or corneal implant called Xenia from Germany? And do you have any input or advices for patients with regard to the utilization of this implant?
Got it. Yeah. So I have heard of the Xenia implant, obviously not available here in the US just yet. And it uses, actually, it's kind of this is a great question to piggyback off of stem cells, because it uses this collagen that we're talking about. So what makes the main portions of the cornea. So it uses collagen, really from animals, the collagen it starts, and they're creating basically what we call lenticules that can then be placed. They cross-link the collagen, and then they can place it into the cornea to try to reshape it. This collagen that is inserted has no cell structure, so it's a sterilized piece of tissue. But one of the things that's very promising about using this kind of technology is that it should be very inert to the eye. You're putting the natural collagen from the cornea back in. So there are a lot of actually iterations of this happening right now. We're actually a part of a trial that's going on by us, where we're using sterilized human collagen. So we're using sterilized tissue that goes through a process called gamma irradiation and then a sterilization. So there is also no cell structure to it. And using that tissue to reshape the cornea. So we call this procedure CTAC, which is a customized tissue addition for keratoconus. There are multiple iterations of this. There's something called Keranatural. There's something called CARES, which uses fresh tissue. We are working with CorneaGen on the gamma irradiated tissue. But what we're learning now is, our options used to be, for example, something like Intacs, where we were placing essentially what was plastic, PMMA, into the cornea, which is inert to the cornea, but has a lot of limitations to how we can use it. You have to be thick enough in your cornea to put it in. We know that a certain amount of patients have to have it removed because of inflammatory reasons. And if we can use natural collagen in the cornea, we take away a lot of those parameters. So we can put the tissue into thinner corneas, much more advanced cases, get much more flattening, which is really what we started to see. So Xenia really falls into that category of treatment. I think we're still learning about whether a lenticule, this kind of circular structure placed over the pupil, is going to work better, or the ring segment more similar to what Intacs was like. So we're still, kind of in the process of working that out. But clearly, placing collagen in the cornea it's happening now, and that is the future of keratoconus surgery for sure.
Yeah, and just and the great, so great to have an expert here who's currently involved in these, cutting edge research. And for those people who may not be as familiar as what this sort of, whether it's your CTAC or Xenia implant, obviously none of it is FDA approved currently. That's why we need research work and have people like Dr. Greenstein to kind of lead the research. But for those people who may not be understanding why this would help, the thickness of the collagen matrix or these tissue can be customized to the point where you could have thinner, sort of think of it as padding, right? So the area that keratoconus is thinner and that protrudes outward, we could have a little bit thicker padding there, a little bit less on the side where you have thicker tissue, and therefore you're evening out the surface of the curvature on the front, and so that overall your eyes look rounder and smoother, and you could see better, or at least have better vision potential. Is that also being done? Because what I understand from Xenia is they seem to take the larger sort of disc approach. I don't see them taking the smaller, whether segmental or what you're doing, which I think you're actually inserting more focalized and smaller disc. So what's that like for what you're doing with CTech?
Yeah, so we've done both. Actually, the challenge with the lenticular approach, and I think we're going to get there. And there's certain advantages. There's basically certain patients are probably going to benefit. What we're going to find out, certain patients benefit from one, certain patients benefit from the other. The beauty of the cornea is its clarity. So the amazing thing about the cornea is that despite these pancakes of collagen that kind of sit one on top of the other, the cornea remains clear. So anything that we add has to maintain that clarity, and especially if we're going to add it over the pupil. And so some of the tissue that we use has been, we've been kind of working on trying to figure out which is going to maintain the most clarity for us. Clearly, if it's thinner, it'll be more clear. And we're going to get there, I think, on the lenticular side. Where we've seen a lot of promise is on the ring side. So because I think everybody would realize is that nobody is the same. And so everybody's cornea is a little bit different. And some corneas have a big area that's steep, some have a small area that's steep, some are thicker than others, and also within each person's cornea, it's different. And the beauty of using collagen is that we can mold it in almost any way that we want. We can make the rings wider, we can make them more narrow, we can make them thicker or thinner, and we can even potentially down the road make them even different sizes in one cornea. And so we can take areas that are flat and make them steeper, flatter, and really kind of create that dome round shape that we're all looking for in the irregular cornea. So we're at the early stages of this, but the early stages have been incredibly, incredibly promising. We've been using this, we started off by using this primarily in patients who really corneal transplant was their only option. And multiple of those patients did great. Where they avoided corneal transplant, and now we've started to move it into more moderate and even a few more mild cases, and we've been really encouraged to see very, very similar results.
And were there, so to dovetail on what you just said, you already covered quite a bit on who are good candidates that you consider for this CTech procedure. Are there other more specific criterias of from the patient point of view in terms of maybe their prescription or maybe their severity of their keratoconus, then they're a good candidate for possibly this CTech procedure? Do you have any advice on that?
Yeah, I mean, the beauty of this procedure is that we're kind of, using it in a very wide variety of patients now. Scarring is still a limitation because if you have scarring over your pupil, this is not going to get rid of that scarring. It doesn't mean it can't be used as part of a stepwise approach, but scarring can definitely be a limitation to being able to put this in. But we're no longer limited by your cornea being too thin or your cornea being too steep. So with that we have not found to be a limitation. And prescription-wise, we also can work with pretty much any severity of prescription. I think the one thing to understand with any of these procedures is its role, which is, these procedures are not going to just fix your vision with no glasses or contacts and make it perfect just by putting these segments in, especially in more severe cases. Where we've been using the CTech segment is kind of in it as an in-between. So for some patients, it improves their glasses vision enough that they no longer require their contacts. For a very few, we've actually gotten to the point that their glasses-free vision has been good enough that they've pretty much avoided contacts. But for most people, really this is part of their general kind of refractive treatment. And we like to approach keratoconus with kind of a three-step approach. We want to stabilize the cornea. That's obviously cross-linking, as we all know. We want to get the cornea as regular shape-wise as possible so that we hope to get glasses vision as functional as can be. And then we use our other approaches, specifically contact lenses, to get people the best vision possible. And what we found is that for a lot of patients where we put these CTAC segments in, and again, most of these patients have been very advanced, these patients couldn't wear glasses at all. So they were dependent on their lenses 14, 16, 20 hours a day. And that over time takes its toll. But if we can reduce that wear to 8 hours a day and give them functioning glasses, not perfect, but function where they can, be out of their lenses at home, out of their lenses on the weekend, it not only extends the use of their contact lens wear longer term, but it really gives them an additional freedom that they never had before.
Yeah, and that's just so important because it's all about restoring the quality of their life and giving them that independence back.
Yes.
So that is so great. And I think some of our audience may, because as knowledgeable as they are, they may already be thinking, well, it's an implant, it's not a transplant. But they recall the times when they go to see their eye doctors and they are being told about lifespan if it were a corneal transplant. This being a decellularized implant tissue that only contains the collagen matrix, is there are you concerned, is there something that you advise your patient about a possible lifespan that requires a second implant?
So, I mean, we do tell patients up front that we don't know the answer to this entirely. We've been placing them for a few years now. We have never seen a rejection up to this point. Theoretically, it might be possible, but we think it is extremely, extremely unlikely. By decellularizing, by taking the cells out of the tissue, by sterilizing the tissue, and the way these are placed, it would be very unlikely to experience rejection of this kind of tissue over time. In fact, what we think is happening, and what some of the studies have bared out from lab research, is that your own natural cells start to populate into this collagen. So it almost gets incorporated into your own cornea. And so unlike transplant or traditional transplant, we do not think that these are going to reject. We don't know. It's always going to be a rare case that maybe we can't anticipate for, but we don't keep patients on long-term drops or anything for having this in. This is the other advantage of this not being over the pupil. The clarity of the tissue, which is amazing. Even if it became a little hazy over time, it's not going to affect your vision because it's not sitting in the area and it still should work just as well. So right now we haven't seen it. We don't think it should happen. We think it's actually going to be pretty natural to the cornea, but obviously time will tell.
Yeah, well, that's such a great point. And just before we fully saturate our audience brain with all the new knowledge you're giving us, there's one more question that I really feel like it ties in really well with the theme of today, and that is, what other medical surgery, whether it's coming down the pipeline or the horizon or currently. So let's get to that question. Paul from United Kingdom asks, are there any current or future treatment options, potentially including laser-based surgery, that you see for people with keratoconus?
Yeah, well, I think we've kind of talked about the future a lot, and there's always more on the horizon. But I think these collagen-based treatments, the stem cell treatments, this is probably top, certain drop treatments that are going to help with crosslinking. Those are kind of the future on that end. I think talking about today and laser guided treatments, the big advancement has been something called topography guided laser. So one thing that we have the ability to do now is use the maps, use the topography of patients' corneas, and then use the laser to reshape the cornea. So whereas LASIK used to, or which obviously you can never have in keratoconus, or PRK used to just use your prescription and try to reshape the cornea. And in fact, for an irregular cornea, it would make it worse. We can now take the maps of the cornea and essentially make the cornea more regular shape. So we can take the steep portions and the flat portions and kind of level them out for each individual patient. So that is really currently what has changed the game in our surgical management of keratoconus, because we can really get patients who are having difficulty with their contact lenses many times into glasses. or even soft contact lenses. You know, we can sometimes we can even get patients out of their glasses and contact lenses. And with this and cross-linking, using this is off-label, but the devices are FDA approved. And this in combination with cross-linking can stabilize the cornea and then reshape it and really give some amazing results. We are still separating the two, so we do them generally on different days, but it really gives a combined approach for patients, which they never had before. The one thing about the laser, which we have to be very careful about, is all lasers remove tissue to do this reshaping, and we're working in already thin corneas. So that can be our limitation with laser treatment still, is that we definitely do not want to thin corneas too much. So we work in a very, very small area. We thin it very, very little when we do this. And you must have cross-linking done. That is a must to make sure that the cornea remains stable when we do this kind of a procedure. But the results that we've seen with topography-guided PRK in keratoconus have been really amazing. We've even actually been able to take patients who've had previous intacts and had some improvement and do the PRK on top of their intacts. So we don't take their intacts out. We actually do it on top of their intacts, and we can make their vision even better. And we've had tremendous success with that.
Well, that's great. Many of you see that I probably was sporting a silly smile on my face because I'm thinking back to the time where Dr. Greenstein would be like there late in the clinic compiling his study data, and I would be working on my patient's chart. And this just really brings me back to like, what, 10 years ago? I can't believe how much time has passed.
late nights in what felt like a little closet room at the time.
Right.
With a bunch of computers packed in, all trying to make room for one another.
Well, I knew he was brilliant at that time, and he just does not stop to amaze me. And I really want to thank you for making time for us today, Dr. Greenstein.
Well, absolutely. Thank you for inviting me. Like I said, it's really an honor. And it's great to see you virtually, and hopefully we'll see each other in person soon.
I hope so too. So I want to throw the mic back to Taylor. This is our last episode of 2021. I hope everybody had learned a lot as much as I have. Taylor, any departing comments for us to close out the year?
I just want to thank everyone for tuning in. Again, this is episode 9, so it's been a really fun year, an exciting year, and we're excited to continue this in 2022. And I want to thank Dr. Greenstein for joining us today, sharing your perspective and your expertise. It's been great, so thank you so much.
Thank you for having me.
Next month, look for another Chang Reaction episode with answers to more questions about all things keratoconus. And if anyone listening has a question that they would like answered in a future episode, please go to the NKCF website, and under the For Patients tab, you'll find the Ask the Expert Chang Reaction. You can post your question there and we'll try to answer it during an upcoming episode. And lastly, NKCF operates with the support of friends and donors. If you feel the urge to support us, you can make a much appreciated online gift to the UCI Foundation. In closing, I again just want to thank Dr. Greenstein and Dr. Chang for taking the time to work with us this month, and I'm wishing everyone a happy holiday season. Thank you.
Thank you, everyone.
Bye. Thank you.